Hello, hello everyone. Thank you for joining. I'm Dr. Harper from the Cleveland Clinic. I'm joined here by Dr. Tom Ung, Ung, Ungprasert, also of the Cleveland Clinic. And we are really excited to give a series of talks today on managing sarcoidosis. Dr. Ungprasert is a member of the sarcoidosis team here at Cleveland Clinic. He is a rheumatologist, and his focus in sarcoidosis is on treating all of the joint manifestations of the disease. And I'm really excited to be able to have him give us a talk on on managing pain and joint issues in sarcoidosis. And with that, I'm going to hand it over to you, Dr. Ungprasert.
Thank you so much, Dr. Harper. Hello, everyone. My name is Dr. Tom Ungprasert from the Cleveland Clinic. Today, it is my great honor to be here to discuss with you all about an important topic in managing or care of people with sarcoidosis. Today, I'm going to talk about pain in people with sarcoidosis. And let me share my slide now. Okay, I think my slide is on now. So today I'm going to discuss about pain in sarcoidosis, which is an important topic in care of people with sarcoidosis because pain is an extremely common manifestation and extremely common symptom of people with sarcoidosis. Up to about 50 or 80% of people with sarcoidosis, they do suffer from pain in multiple surveys. So today I will talk about 4 common causes of pain in people with sarcoidosis, including inflammatory arthritis or sarcoid arthritis, wear and tear arthritis, or medical term for that is called osteoarthritis. Third, neuropathy or pain from the nerve, especially from what we call small fiber neuropathy, and last, chronic pain syndrome or fibromyalgia. Let's start with sarcoid arthritis. Sarcoid arthritis is basically inflammation of the joint that is caused by sarcoidosis itself. It is inflammatory in nature, so in this situation, we would expect to see pain, swelling, tenderness, redness, and warmth of the joints. And we also expect to see a high inflammation number like high set rate and high CRP. Usually, patients with sarcoid arthritis, they usually describe their pain as dull and achy in nature, or sometimes when the pain is bad, it could be stabbing pain as well. Sarcoid arthritis tends to affect the larger joints, including the ankles, knees, and wrists. Okay, and most of the time, more than 90% of the time, ankles are affected in people who suffer from sarcoid arthritis. The second causes of pain in people with sarcoidosis that I want to talk about is osteoarthritis, which is basically a wear and tear changes that is caused by age. This is something that is common in people with sarcoidosis because it is very common in general population. Like I said, the mechanism behind osteoarthritis is basically wear and tear changes or degenerative changes that is caused by aging. So it is almost inevitable for all of us to suffer from osteoarthritis at some point in life when we become older. And because it is a wear and tear change, it is a degenerative process. There is no inflammation involved, so we would not expect to see warm swelling or tenderness that we see in sarcoid arthritis. And also, patients usually describe their osteoarthritic pain as dull and achy in nature, and it can be stabbing as well when it becomes really bad. And the joints that are affected by osteoarthritis is usually different from sarcoid arthritis. In sarcoid arthritis, we usually see only large joints like the hips, like the ankles, the knees, and the wrists are being affected. But for osteoarthritis, you can see the combination of both large and small joints, like the joints of the hands or the first toe joint can be affected by osteoarthritis as well. The third disease that I will talk about is a condition that is called small fiber neuropathy. Small fiber neuropathy is a kind of neuropathy that happens to a small nerve fiber, and the mechanism behind this small fiber neuropathy is not well understood, but we believe that impairment or loss of the small nerve fibers play a significant role in the development of pain. Small fiber neuropathy can happen with or without any underlying illness, okay? And when it happens with underlying illness, diabetes is one of the most common underlying disease, but autoimmune diseases like sarcoidosis can also cause small fiber neuropathy. And this is particularly common in patients with sarcoidosis. Some studies suggest that we can see small fiber neuropathy in up to like 1/3 of patients with sarcoidosis. The kind of pain that patients with small fiber neuropathy will describe going to be a little bit different from sarcoid arthritis and from osteoarthritis. Most of the time, patients would describe their pain as more like a burning pain, not like a dull and achy pain in arthritis. And this pain is usually accompanied by numbness, tingling sensation, and also skin sensitivity. In addition to the pain, small fiber neuropathy also affect our autonomic function because small fiber nerve also has an important role in the control of our autonomic nervous system. So in addition to pain, patients with small fiber neuropathy, they also tend to describe autonomic symptoms such as palpitation, dizziness, skin flushing, change in their sweat pattern, and also bowel habit change. The pattern of pain of people with small fiber neuropathy can be different. Some people may describe patchy pain, like the first picture on the A picture on the screen. Sometimes the pain can be more primarily on the extremity, especially in the proximal part, or can be in the distal part of the hands and the feet. Or in some patients, they may describe whole body pain, like the picture on the right side. It is somewhat difficult to diagnose small fiber neuropathy, and it requires a more sophisticated test that cannot be done everywhere. We usually rely on skin biopsy to diagnose someone with small fiber neuropathy. We would expect to see a loss of nerve fiber density underneath the skin. We can look at that under microscopy. And sometimes we also do autonomic testing to try to find an evidence of autonomic dysfunction that can be seen in addition to pain in small fiber neuropathy. And the tests that we usually do include what we call quantitative pseudomotor axon reflex test, or QSAT, which is basically the test that we measure how well you sweat in response to temperature or to chemical trigger. And we can also do what we call tilt table test, which is a test that we monitor your heart rate and your blood pressure in response to position change. If you want to learn more about QSAT and tilt table test, we have this link below from our Cleveland Clinic website. I put the link below this slide if you want to learn more about them. And fourth, the fourth disease that are one of the most common causes of pain in patients with sarcoidosis is chronic pain syndrome or fibromyalgia. This is also a disease that is not well understood. We do not know the mechanism behind chronic pain syndrome or fibromyalgia with certainty, but we believe that it is caused by what we call brain hyper-irritability, which means that the patient's brain tend to be too active, tend to be very irritable, and the brain tend to interpret any signal that come from your nerve as come from the nerve as a pain. So even sometimes someone just touch the patient with just light touch because of the hyper irritability, the brain can interpret that touch signal as a pain, and the patient will suffer from pain all the time because of the misinterpretation of their brain. This is also something that we know that it is non-inflammatory. This is not an inflammatory disease, so we don't expect to see warmth, tender warmth, or swelling or joint fluid on physical exam. Chronic pain syndrome or fibromyalgia is common in people with sarcoidosis because it is also common among general population. Some surveys say that about 2 or 3% of general population do suffer from this condition. And it is also something that is kind of difficult to diagnose because we don't have one specific test or marker to diagnose someone with chronic pain syndrome or fibromyalgia. It is basically a diagnosis of exclusion, which means that we need to exclude other possibilities first before we can say that someone suffers from chronic pain syndrome or fibromyalgia. However, sometimes on physical exam, the physical exam can provide me some clue that we are dealing with chronic pain syndrome or fibromyalgia. If we do see a pattern of tender spot in the specific area of the patient body, sometimes that presence of soft tissue tender spot can help me with the diagnosis. And this is the tender spot that we are talking about. There are unique set of spots in our body that when they are super tender in that area, it can provide me some clues that we are dealing with chronic pain syndrome or fibromyalgia. So it is really important to identify the cause of the pain. It is important for providers to identify what is the illness or what is the disease behind the patient pain, because treatment for these conditions, they are different. If we are dealing with sarcoid arthritis, it means that the sarcoidosis is still active, and we need to step up on our treatment to try to get sarcoidosis under control. Treatment would include something short-term like steroid or NSAID to abort the inflammation, and after that, we also need to either give our patients immunosuppression medication like methotrexate, hydroxychloroquine, or sulfasalazine to try to calm down the inflammation, to calm down sarcoidosis. And if that fails to work, we may even need to escalate treatment to biologics, something like infliximab or adalimumab. For osteoarthritis, this is not an inflammatory condition, so treatment with steroids or immunosuppression medication or biologic agent would not help. For management of osteoarthritis, we would focus on pain control using something like non-steroidal medication, Tylenol, or most of the time we may also need a stronger pain medication in the group of what we call nerve stabilizer, something like gabapentin or pregabalin or duloxetine to help managing their chronic pain. Because again, osteoarthritis, it is a wear and tear change. It is a degenerative process of the body, so it won't be reversible, and this is a condition that will cause chronic pain. So we need a good long-term pain management strategy to help our patients to be able to function. And in addition to pain management, I almost always encourage my patient to participate in physical therapy, because I know that if they do a good amount of exercise / physical therapy, it can help them regaining their strength in the muscle, in the tendon, in the ligament, allow their joint, and that can help absorbing the amount of pressure to their joint, and over the long run that can help with the pain and slow down any further damage to their joint, to prevent further damage, to make their osteoarthritis even worse. And at the end of the day, if physical therapy and pain management are not good enough, we are going to talk about surgery, something like hip replacement surgery or knee replacement surgery, if that is something that we think that it can help our patient to regain their function and to control their pain. For small fiber neuropathy, this is also a tricky situation. This is also a disease that is quite difficult to manage. Most of the time, we're gonna focus on pain management first with something like Tylenol or non-steroidal medication and nerve stabilizer. But I have to tell you that in our experience, pain control alone is usually not sufficient to help patients with small fiber neuropathy. And most of the time, we may need to consider something even stronger. And in our Cleveland clinic experience, we think that treatment with a specific medication called intravenous immunoglobulin or IVIG can be helpful. And in our experience, up to about 2/3 of patients with small fiber neuropathy, they do have a good response to IVIG treatment. For chronic pain syndrome or fibromyalgia, treatment is also our treatment would also focus on pain management with Tylenol, with non-steroidal medication, with nerve stabilizer medication. But usually, pain from fibromyalgia, it does not respond well to non-steroidal medication or Tylenol. So most of the time, I usually offer treatment with nerve stabilizer to my patient right away, and even more important than that. The treatment for fibromyalgia, usually we don't rely on just pain management or pain medication alone. I also always encourage my patient to try non-pharmacological therapy. Something like regular exercise can be helpful. Sometimes if the patient have enough resource or time, I also recommend them to undergo what we call cognitive behavioral therapy with our therapist to help them better deal with their pain long term. And alternative treatment, something like Tai Chi or acupuncture, can be helpful in this situation as well. All right, that is my talk for today. I'm gonna hand this back to Dr. Harper.
That was fantastic. That was fantastic, Tom. Thank you. I thought we could pause now and answer some of the questions that popped up in the chat, and also some that were sent in about joints. I saw two people asking, how do you differentiate between small fiber neuropathy and fibromyalgia?
So that would be difficult without a test, and we like I said, we usually rely on skin biopsy to say whether someone suffer from small fiber neuropathy or not.
Awesome, makes sense. So it sounds like fibromyalgia is more of the general diagnosis, and a subset of them will have small fiber when we do all of our advanced testing.
Yes.
And then what else did we had questions in the we had questions that people had sent in about how do they tell if their joint pain is coming from sarcoidosis or coming from osteoarthritis, like you were talking about.
So it is important for you to see a rheumatologist like me, a rheumatologist who is experienced in performing joint exam, because this is something that we need to get a good history from you. We need to put our hands on your joints and feel your joint and determine whether we do see any evidence of active inflammation in the joints or not. I know that not a lot of rheumatologists are interested in sarcoidosis, so it may be a little bit difficult for you to find one. But I think at the end of the day, if you do suffer from joint pain, it is important for you to find a rheumatologist who can tell you whether this is caused by sarcoidosis, caused by inflammation, or it's more like a wear and tear change from osteoarthritis.
Awesome. Thank you so much for that. And then the final question we got sent in was, when someone has joint pain and it's not improving with steroids, what are your next moves?
So I assume that this is a question about sarcoid arthritis. So if my patient does not respond well to steroids for the management of their sarcoid arthritis, then I'm gonna escalate their treatment to something even stronger than just steroid. I usually start with immunosuppression medication, something like methotrexate and plaquenil have a good track record in helping my patient with sarcoidosis. And if immunosuppression medication does not provide them significant pain relief or inflammation relief, I will step up my treatment even further to biologic medication. And the two biologic medications that I use a lot for sarcoidosis arthritis include infliximab or Remicade and adalimumab, which is Humira.
Awesome. That's fantastic, Tom. Thank you so much for your input today. I'm gonna share my screen, and we're gonna transition a little bit from practical advice to talking a little aspirationally about some things that are coming down the pipeline for sarcoidosis. So I wanted to talk about three main classes of studies. And those are trials learning to understand better how to use the drugs that we have for sarcoidosis, like steroids and methotrexate. After that, I want to talk about some exciting work looking at drugs that aren't currently used for sarcoidosis, and seeing if potentially they could be helpful for sarcoidosis treatment. And then finally, I want to talk about two drugs that are currently being tested in phase 3 clinical trials to treat sarcoidosis. I really want to highlight before I get into this talk that I'm talking about the future here. Almost none of these trials are completed, so I am not recommending any of these drugs for people now. But I wanted to talk about what is coming in the future and give a sense of hope. So first, I wanted to talk about why we don't have all the drugs that they have for other diseases. This is a slide looking at the number of trials for drugs in various diseases. And as you and this is as of May of 2023. And you can see rheumatoid arthritis has multiple drugs that have been tested. And pulmonary hypertension, which is actually a pretty rare disease, also has a wide range of drugs trialed. And sarcoidosis over here has a very small number of drug trials as of last year. And this kind of highlights a gap in the literature. And it's also one of the reasons I chose sarcoidosis, because it really is a disease where there's so much work waiting to be done. So first, I want to talk about an ongoing trial looking at methotrexate or prednisone. This is really a very basic question to be asking. Which is better in sarcoidosis, upfront steroids or upfront methotrexate? In this trial, they've chosen to look at this in cardiac sarcoidosis. And I believe they've done that because cardiac sarcoidosis has some pretty clear end points. Your heart's either working or it isn't, and it's easy to show changes over time. In this trial, you can see one group of patients, after they're diagnosed, will be treated with prednisone 30 milligrams every day for 6 months. The second group is going to be treated with methotrexate 20 milligrams for 6 months. And they're also going to be treated with prednisone that'll gradually taper down to 0 over 4 months. I am very excited about this trial, not just for what we're going to learn about treating cardiac sarcoidosis, but I think this is going to give us some really good information comparing what side effects patients get with long-term high-dose prednisone compared to patients who are able to be weaned off by using a second drug. The second trial I want to talk about is looking at the other end of the treatment timeline. This study is looking at how long should someone be on infliximab after they've been started it for sarcoidosis. This is also a question we come up against all the time in clinic. And currently, I don't have a lot of data to tell me what to do when someone has been on infliximab for a year or 6 months. In this trial, they are looking for patients who were started on infliximab at least six months ago, and half of them are going to stay on the infliximab, and half of them are going to stop the infliximab. And they're looking at two very important endpoints. One of them is a very obvious endpoint. You obviously want to know, are people developing sarcoidosis again when we stop the drug? I'm also very interested in the second point of looking at quality of life. Often often when we do trials, we focus in really narrowly on the drugs, and we forget to ask and we forget to ask people how they feel. I'm excited that they are looking at quality of life in this trial, because you can see the group of patients who stop infliximab are on a higher dose of methotrexate compared to the patients who stay on the infliximab. It's possible we could show no difference in the relapse rate, but it's possible that the patients who stay on the infliximab could have a better quality of life. And this trial is looking for that as a possible outcome too. And I think that's something that is really important for trials as we go forward in sarcoid, that we're looking not only at organ involvement and disease control, but also how we are impacting patients' lives. The final trial I'm going to talk about, looking at drugs that we currently use for sarcoidosis, is the CAESAR trial. This trial is looking at how good Plaquenil, also called hydroxychloroquine, is for treating non-pulmonary sarcoidosis. This trial will be really helpful because Plaquenil is a drug I frequently reach for when patients are having kind of mild symptoms of sarcoidosis. We think of it as being good for joints. We think of it as being good for calcium, and we think of it as being good for skin. What we don't have are any trials really showing that definitively. What we have is our clinical experience. And I think this study, where they compare Plaquenil to placebo, will be really helpful. This study also highlights a new trend in sarcoidosis trials that I think is very helpful. In this trial, both groups of patients will be on a prednisone taper. This is good, I think, for two different reasons. One, I wouldn't want to give anybody with sarcoidosis only a placebo, because we do have numerous drugs that do work for sarcoidosis, and I wouldn't want to leave someone without treatment. The other benefit of this steroid taper is we are able to compare how low of a dose of prednisone the patients in the two groups are able to get to. And that is more of a holistic measure of the control of the sarcoidosis than just looking at a picture of someone's skin. Next up, we're going to talk about trials looking at using non-sarcoidosis drugs for sarcoidosis indications. There are a lot of different rationales in these trials. This trial that is proposed to go on in the Netherlands is looking at actually treating a potential cause of sarcoidosis. There's a particular bacteria called P. acnes that lives on just about everybody's skin. And in Japan, they have a lot of data suggesting that this particular bacteria in some people may trigger their sarcoidosis. Since the bacteria lives on everybody's skin, the question came up, if we treated the bacteria with an antibiotic, would that improve sarcoidosis symptoms? In this trial, they're looking at patients who have sarcoidosis of the skin. They're giving half of them antibiotics and half of them a placebo, and they're looking to see, are they able to improve the sarcoidosis. So that'll be interesting coming forward to see if one day we're actually able to attack the root cause of sarcoidosis in some individuals. I don't think P acnes is the cause of sarcoidosis in every patient. So I don't know how widely applicable this treatment will be in the future. Another way to treat sarcoidosis with a non-sarcoidosis drug is to kind of ignore all of the inflammation going on and treat the problems that the inflammation causes. In a small percentage of sarcoidosis patients, they can develop pulmonary hypertension, which is when the blood vessels that go from the heart into the lungs narrow. When these blood vessels are narrowed, the right heart has to work much harder to pump blood into the heart. And this can cause low oxygen levels and right-sided heart failure. We actually have a large number of drugs that open up those pulmonary vessels when they're narrowed. There are actually a lot of complications in opening up those vessels, and in some people this can be very helpful, and in other patients it can actually make their oxygen levels worse. So this is something we have to be very careful about. We have one drug called treprostinil, which is a drug that can be given either as an IV drug or as an inhaled drug that can open up those blood vessels. As an inhaled drug, it is also less likely to cause worsening oxygen levels than the drug given as an IV. So in this trial, they are looking to give 10 sarcoidosis patients with pulmonary hypertension this inhaled treprostinil. Now, this is something we call a phase 2 trial. A phase 2 trial is when you're trying to show that a drug may have some efficacy, but you don't have enough patients in it to really show that the drug works for everyone. Clinical trials generally go through 3 phases, where phase 1 is just testing the drug to see if it is safe for healthy volunteers. And then phase 2, you actually give it to the patients who need it, and you start planning your larger trial to get it approved for everyone. Since we are only on a phase 2 trial here, we're still probably several years out from routinely giving treprostinil to sarcoidosis patients with pulmonary hypertension. Next up, I want to talk about sirolimus. And this is a drug that is actually targeted at the inflammation of sarcoidosis. This is a drug commonly used in patients who have had organ transplants as an immunosuppressive drug. And there's some data that the pathway that this drug targets may be actually particularly relevant for sarcoidosis. So there was a trial proposed in France where they were going to look at sirolimus and see if it improved skin sarcoidosis. Sarcoidosis of the skin is a good organ for trials because it is very easy to say objectively, is the rash getting bigger or smaller? In science, sometimes when you're planning on doing something, someone else will do it first. And in this case, a group in the Netherlands was able to show that sirolimus did improve rashes from sarcoidosis. And you can see here the slide of this woman's face that has really dramatically improved with the drug. Outside of targeting the cause or targeting the symptoms or targeting the inflammation, sometimes we look for off-target effects of drugs. Metformin is a drug that is commonly used for treating high blood sugar, but there is a lot of data showing that it may also have anti-inflammatory properties. Because of that, this is a trial where they're looking to see in patients with pulmonary sarcoidosis, will adding metformin help them lower the prednisone dose that the patients are needing to control their disease. This would be a very interesting trial because this would really guide us on how should we manage the diabetes that we often see in sarcoidosis. If there's a drug that'll treat the diabetes and also help the sarcoidosis, that becomes a much easier decision. Finally, I want to talk about the 2 ongoing phase 3 clinical trials for new drugs specifically for sarcoidosis. This first trial is for efzofitimod. This is a drug that is given as an infusion and treats sarcoidosis without having all the severe immunosuppression that we see from other drugs. In this trial, they are giving patients with pulmonary sarcoidosis efzofitimod at a high dose, a low dose, and a placebo. And all 3 groups are getting a prednisone taper. And the endpoint is how low of a steroid dose are we able to achieve over a 1-year trial. We're particularly excited about this trial. It's happening at Cleveland Clinic, and several and several other sites. Here's a description of the timeline. And if you wanted to see, more information about this, Daniel Culver, who is one of the leaders of the trial and the head of our department here, has a really great YouTube video about efzofitimod and how it works and why we think it could help with sarcoidosis. The final trial that I'm going to talk about is namilumab. This is also a drug where the goal is to show are we able to help patients with pulmonary sarcoidosis lower their steroid dose over the course of a year. The trial is very similar to the efzofitimod trial. One thing that I like about this trial is all patients in the trial will get to have the drug. You can see here, where's my mouse? You can see here at the beginning, half of the patients are on placebo, half of them are taking the drug. And then after 6 months, all of the patients get the drug. I think that's a great way to do trials and make sure everybody who volunteers is able to have some benefits. So that is all I have on new treatments. I'm going to pull up the chat and see what we have for questions. And it looks like there are several. The first one I see here is, how do I become a patient at the sarcoidosis clinic at Cleveland Clinic? We're definitely accepting new patients. If you Google Cleveland Clinic sarcoidosis, we have a website for the clinic that has all of the information of how you get in as a patient. And then someone says, is the high calcium you're talking about blood calcium or urine calcium? Both of them can cause issues in sarcoidosis. Often the calcium in the blood has issues, will cause more severe manifestations quicker. The thing that we really worry about with calcium in the blood is renal failure. Scrolling down. Someone's asking about the trial for efzofitimod. Looks like I answered that. Where is Dr. Logan? Oh, I should have introduced myself a little bit better. I'm Dr. Logan Harper. I am one of the pulmonologists at Cleveland Clinic. I work closely with Dr. Ungprasert. What about drugs? About drugs like Keytruda? I believe there's some interest in applying that to sarcoidosis. It definitely isn't something we're doing routinely. Have you heard anything about Keytruda, Tom?
No, I think that it is primarily used in the oncology world right now, and interestingly, we do actually see some reaction to Keytruda that looks like autoimmune disease, like rheumatoid arthritis or lupus. It is a medication that we call checkpoint inhibitor, and it is known to sometimes some people they develop like a reaction that looks like autoimmune disease. I'm not sure how good it would be in treatment for autoimmune diseases per se when one of the side effect could be autoimmune-like reaction.
I totally agree, Tom. I will admit I got my brand name drugs mixed up in my head there, and Keytruda definitely is one where we see the granulomatous reaction. Okay, and then I'm going to go over here to the questions that people asked prior to the course. I'm going to try to avoid answering specific patient specific management questions because I don't know anybody's full medical history, and I don't want to give anybody bad advice. Someone's here is asking, are we able to send out the link? I have confirmation that we are recording the session and we are able to send out the link. So I'm going to work on that after this is done. There were questions about any new treatments. I think we answered that. I think that is about all. I think we answered most of them. Any questions you're seeing in the chat, Tom, that I missed that you think we could answer accurately?
I think that we run through most of the interesting questions.
Okay, great. Well, thank you. Well, thank you everyone for coming. Thank you, Tom. Thank you, Tom, for your presentation. I think it's safe to say this is our biggest turnout for one of these webinars. I'm seeing over 100 participants. So thank you so much, everyone who came out and took the time. And have a good evening.